the PSMA scans are emerging as really very impressive. They're available around the world, except in the United States, where they're regulated by the FDA, and the FDA has not granted utilization yet. But there are two major competitors. One is a more or less a naked PSMA, PYRL, PYRL link, and the other is a gallium link. The gallium link is the one that I've had most experience with. I send a lot of my patients to UCLA. It's close. So I've probably done 40 or 30 PSMA scans. It's unfortunate patients have to pay for it because it's not covered by insurance, so it's about $3,000. But the insights you obtain are really remarkable. And what we're finding is that a lot of the PSA relapses are oligometastatic relapses. They're single nodes or small numbers of nodes, few isolated bone mets, but usually it's oligometastatic nodal relapse prostate, which then means that the patient may potentially be treatable with a stereotactic radiosurgery or a CyberKnife or something like that. And the OBRoncology trial was just published in JAMA Oncology. I was reading it last night again. And the OBRoncology trial did PSMA scans, but they didn't act on them. They used them as a baseline, but they treated the patients with oligometastatic prostate cancer using bone scans and CAT scans. And interestingly, the patients who had oligometastatic disease that was sort of confirmed by the PSMA scan did very well. But the patients whose PSMA scan showed more disease than was treated with the CyberKnife or the SBRT relapsed more quickly, suggesting that a approach of radiating all disease, and this was a Johns Hopkins study, a very well done study, small but randomized, and it wasn't an overall survival endpoint. It was meant to be a relapse endpoint. How long could you keep the patients off hormones? And the Dutch trial also was published or reported out lately. That was called the STOMP trial. And then we have the SABRE trial. All of these are in the same general category of trying to treat oligometastatic disease. And in the world of prostate cancer, OBRoncology is the first one out. STOMP from the Netherlands had a few prostate cancer patients, and SABRE had a few. There's another trial out called RAVENS, or soon will be out, called RAVENS, which is a much bigger trial looking at PSMA to guide oligometastatic therapy. Sorry, I'm digressing, but it's become a very complicated field. And so the PSMA scan, to summarize, is identifying disease that is usually small volume, may be oligo or solitary metastatic disease, and leads us to think that radiotherapy, potentially combined with hormone treatment, may have potential to eradicate the cancer. I'll tell you a brief story about one of my patients who I've been treating. He had very bad advanced disease early on, and then relapsed with a PSA-only relapse, and he just got his scans back. He's just got 2 nodes left, both in the pelvis, both on the right side. And so he's basically now going to get CyberKnife stereotactic radiosurgery to the only remaining cancer. And I told him this is a good thing. Now, I don't know if the radiotherapy is going to cure him, but it's certainly a modality that I would normally not have used. I would normally have just said, well, you know, we'll just have to put you on long-term androgen ablation therapy, or Lupron with enzalutamide or apalutamide or darolutamide. You're a non-metastatic, if you will, castrate resistant. And now suddenly he's got just 2 nodes and he's going to get started on radiotherapy. So it offers a whole different perspective. In addition, the same guy, you know, who thought now that he was, you know, about to die from his advanced cancer, I tell him, look, you've only got 2 little nodes of prostate cancer. You're not about to die. You know, this would be like an axillary recurrence in breast cancer, or an isolated nodal recurrence in rectal cancer. Yeah, it's not good, but you're not overwhelmed by the cancer. So the PSMA scans are really going to, I think, open up the world of prostate cancer to more specific therapies than what we've had before. And that's probably the biggest advantage. It gives patients a whole different new approach. For example, the study that looked at enzalutamide or apalutamide or darolutamide for non-metastatic castrate-resistant prostate cancer. There's a recent paper suggesting that many of those patients were oligometastatic. They had a PSMA scan that only showed 1 or 2 nodes. So it's no wonder they lived 3 or 4 years. And if you can avoid those highly expensive oral therapies in favor of radiotherapy, you know, huge amounts of quality of life improvement. So I'm very optimistic. I'm looking forward to seeing it approved. There have been studies directly comparing the Blue Earth scan, the flucyclovine, to the PSMA scans, and the PSMA scans are better. They're still not quite accurate at the very low PSA levels. When the PSAs are less than 0.5, they're not, the PSMA scans are not that accurate. But on the other hand, the Blue Earth doesn't really become accurate until above 5. Whereas even at the very highest PSA levels, Blue Earth scans are about 70%, whereas PSMA scans are about 90%. There are some issues. Not every patient has a positive scan. The tumor has to produce PSMA, and not all prostate cancer metastatic sites produce PSMA. So you have to be, you know, somewhat cautious in not over-interpreting a negative scan. And I do have patients like that where they have a PSA of 8 or so and their scan's negative. And I just say to them, well, you know, it appears that you have a PSMA negative tumor, just like you can get a PSA negative prostate cancer. So there's limitations, but we hope this year it gets approved, and we hope that the FDA will grant it. Whether insurance will pay for it or not is another whole question.